that you'll have to look for are on contrast enhanced scans if you see within the transverse sinus a well demarcated, relatively rounded area of non-enhancement. This is typical for Pacchionian granulations or arachnoidal granulations. They are never present within the jugular bulb. They are rarely present within the sigmoid sinus, but they are often present within the transverse sinus and the superior sagittal sinus. And they can pouch out from the dural lining into the sinus, as can be seen here on this scan. Another area where we very often see Pacchionian granulations is in the transition of the vein of Galen towards the straight sinus. This is not a sinus thrombosis, this is an arachnoid granulation. Another false positive is depicted here. If you see this scan, the major question that you have to ask yourself is this a thrombosed left transverse sinus? Or maybe is this a hypoplastic sinus? Because there are lots of like anatomical variation in patients with the venous sinuses, and it may very well be that this sinus was congenitally not present. And in order for you to make this diagnosis, I strongly encourage you to look at the CT and look for the size of your jugular bulb. If you see that your jugular bulb on the ipsilateral side is very small, then your transverse sinus is likely to be hypoplastic. And here another example where you can see very nicely that this patient's jugular bulb was hypoplastic. In the pediatric age group, an important false positive is the so-called pseudo-empty delta sign that is related to subdural hematoma that is hyperdense. Then it appears as if there was an empty delta sign, and this is common in the neonatal age group and should not be mistaken for sinus thrombosis. What about this patient here? Does this patient have bilateral sigmoid sinus stenosis or sigmoid sinus occlusions? Well, the problem of three-dimensional phase contrast MRA is that you have to predefine the for these phase contrast MRAs the velocity that you are encoding. And if there is a high velocity gradient, then you may not be able to visualize the flow because it's outside of the phase encoding that you are putting onto this MR venography. And this is often present in patients who have high degree stenosis, as in this case here. So remember for these patients to not only look at your phase contrast MRV, but multiple different forms, especially contrast enhanced MR venographies. Another false positive that I would like to demonstrate is in this child here, where in children, you know that there is a higher hematocrit. And if you have a high hematocrit, then your sinuses will be normally somewhat more hyperdense. And this is related to the relative polycythemia that children have. So this is not a sinus thrombosis. And this can be really very hyperdense in the neonatal age group. So in the neonatal age group, you have a very much increased density due to a fetal hemoglobin that looks as if it was thrombus, but you would have to do, in this case here, of course, additional imaging to identify whether this is truly enhancing, i.e. normal, or whether you have an empty delta sign. What are the false negatives in sinovenous thrombosis? False negatives are related to the fact that certain MR techniques that we are using are innately T1 weighted. For example, a phase contrast angiography is T1 weighted, which means that everything that is primarily hyper intense on T1 will be demonstrated as a high signal, including thrombus. This is the same patient, and on two-dimensional phase contrast angiography, you would think that this patient has a patent superior sagittal sinus. However, if you look at the contrast enhanced scan, you see that there is significant thrombus formation within the superior sagittal sinus that was simply not visualized because of the methemoglobin signal within the superior sagittal sinus that appears bright on the phase contrast angiography, and because of the fact that surrounding a non-occlusive sinus, you will still see flow. So here the non-occlusive thrombus leads to flow that is then visualized on this 2D phase contrast angiography. You can also have false negatives if you choose the wrong delay of imaging. Here's a patient who has been imaged more on the arterial side, and you would say that this thrombus or this sinus is well opacified. However, if you look at the unenhanced scan and at the venous delay, you can see that on the unenhanced scan, we have a primary hyperdense sinus, and on the venous scan, you see an empty delta sign. So if you are in an arterial phase, you will not see the empty delta sign because the other veins have not yet shown up, and you will see the hyperdense signal of the hyperdense clot. Therefore, finding the right delay is something that is extremely important to avoid this pitfall of venous thrombosis. Or look at this patient. A very dense sinus may be difficult to differentiate from normal enhancement. And therefore, if you are only doing a contrast enhanced scan, you may not be able to identify whether a patient has a sinus thrombosis. So your major caveats in sinus thrombosis are indicated here, the false positives and the false negatives. Our imaging protocol in sinovenous thrombosis is that we like to do a combination of techniques. I strongly believe personally in CTV. However, this is a lot of radiation for the pediatric age group. If you go for MR, choose a combination of techniques, including T2 TSA, T1 spin echo plus and minus contrast, flow techniques and dynamic images, or contrast enhanced MRV. And here's an example for this contrast enhanced MRV. The second now cause and large disease entity that I would like to focus on for pediatric stroke are vasculitis forms. And for vasculitis forms, we again have to look at false positives, false negatives, and a couple of not only pitfalls of imagings, but also some pearls of imaging finding in vasculitis. From an imaging perspective, in vasculitis, you will see in the young age multiple areas of ischemia that are often preceded by fever. In vasculitis, in the pediatric age group, you mainly have to think about varicella vasculitis. So a previous varicella infection is often present in these patients. On MRA, go for your best time of flight MR angiography possible. So for us, this would mean that we go for 3 Tesla rather than 1.5 Tesla. And then you'll have to look for a beaded appearance of your blood vessels. So if you look at this ACA on the right side, in this pediatric patient, you will see that there's narrowing, dilatation, and narrowing that indicates this patient's vasculitis. And then on the digital subtraction angiography, you can see very nicely this beaded appearance, not only here in an MCA vessel with this pearl on a string sign, but also here within this vessel with a sausage on a string sign where you have narrowing, dilatation, and narrowing. And the more closer you look, the more abnormal vessels you see all over the place here with this beaded appearance, classical for vasculitis. The location and type of artery hit by the vasculitis varies depending on the causative agent. So a Takayasu vasculitis will hit the large vessels. A Wegener vasculitis will hit the small vessels. But a lupus vasculitis will hit the smallest vessels that are even so small that you will not be able to visualize them on digital subtraction angiography. Varicella vasculitis likes to be focused on the proximal M1 segments. So here we have an 11-year-old boy who presented with a left hemiparesis related to a perforator ischemia. And on time of flight MRA, you can see a focal narrowing of the M1 segment. When you see this, always think first and foremost varicella vasculitis. This is the diagnostic angiography where you can see the beaded appearance right here at the M1 segment. The other thing, especially and unfortunately in Toronto, that you'll have to think about when you have a young patient with a potential vasculitis, a young patient with stroke, is drug-induced stroke. And here we have to think about varicella, not only, sorry, varicella, but also drug-induced vasculitis. So this is a patient who took amphetamines during a party, who presented with hemiparesthesia, and who has this focal area of ischemia. And as you know, this area here is related to the thalamotuberal arteries, and the thalamotuberal arteries are arising from the posterior communicating artery. And so if you then see that there's a focal stenosis within the posterior communicating artery, you can make the diagnosis of drug-induced vasculitis. Here is a young patient who admitted of taking cocaine, and in cocaine-induced vasculitis, we often see a beaded appearance of the MCA in association with contrast enhancement. False negatives. This is a young patient who presented with multiple areas of stroke. On MR, we couldn't really see focal beading of the arteries. However, at 1.5 Tesla, while this was normal, on 3 Tesla, you could clearly see that the vessels are abnormal. So a low field strength will lead to false negatives. Another example here, young patient, where even the diagnostic angiography was unremarkable, but these are vessels that are so small that you may not be able to visualize them on DSA. In this patient, a biopsy was taken, and you can see that the smallest vessels demonstrate a vasculitic pattern with an inflammatory infiltrate in the distal small blood vessels. So remember that a small vessel vasculitis can even remain undetected on DSA. What are your false positives? Here we have a patient with like what looks first like ischemia, but we don't have any abnormality on the diffusion-weighted sequences. We do see some beading appearances, and this is a disorder of autoregulation or posterior reversible encephalopathy syndrome, or PRES, that we will discuss about later too. Another important false positive for vasculitis is called Fleming syndrome or reversible vasoconstriction syndrome, where we see multifocal areas of ischemia related with an imaging appearance that is very much resembling this of vasculitis. However, the patients often present clinically different. They often present with an acute sudden onset of thunderclap headache. And if you see this in association with this sausage on a string sign, then you have to think about reversible vasoconstriction syndrome. And as the name implies, this is reversible, and the treatment would be with calcium antagonists. And here are a couple of clinical pearls. Think about acute headaches, multifocal segmental stenosis. They do have normal CSF, and they normalize their blood vessels typically within 12 weeks. So some of the false positives and false negatives of vasculitis are indicated here. Keep this in mind when you entertain this diagnosis. What is our imaging protocol in vasculitis? I like time of flight MRA using 3 Tesla, and I do like vessel wall imaging, and I will give you a couple of examples. In vessel wall imaging, we see concentric enhancement of the thickened blood vessel, as you can see here. Normally, you should not see any contrast enhancement within the intracranial vasculature. If you see it, if your vessel is thick and if the enhancement is concentric, think about vasculitis. In this case here, this was a proven giant cell arteritis. Another example here, pre-contrast, post-contrast. This was an 18-year-old boy who presented with a pontine perforator ischemia. You do not think about atherosclerosis in pontine ischemia in this age group. And if you see concentric enhancement of the basilar artery or the posterior cerebral artery here or here, then you know that this patient's diagnosis is vasculitis. Another example here, young patient who presented with multifocal stroke, and on the unenhanced scans, we see nothing, but on the enhanced scans, you see thick enhancement of the entire MCA. If you see this, think vasculitis, and also think drug-induced vasculitis. In this patient, again, it was cocaine abuse that led to these abnormalities. In the acute phase of varicella or chickenpox vasculitis, you can still see contrast enhancement within the M1 as a sign for this focal transient arteriopathy that is related in all likelihood to an immunocomplex vasculitis. If you wait over time, then this enhancement will go away. This is the 1-year follow-up. The enhancement is no longer there. The M1 now looks normal. This type of enhancement is only active in the acute phase of varicella vasculitis. Another very important cause of childhood and young adult stroke are arterial dissections. And the imaging of dissections is that we perform first a very good clinical investigation. If we have an Horner syndrome, meiosis, ptosis, and enophthalmos, think about a dissection. If you have multiple embolic strokes in erratic-looking vessels with a double lumen, think about dissections. If you use your T1 fat-suppressed images and see a crescent-shaped area of mural T1 hypersignal within the wall, think about mural midhemoglobin as a sign for a dissection. If you see strokes that are hemodynamic in nature, as in this example here, and you see again the crescent-shaped T1 hypersignal as a sign of intramural methemoglobin, think about dissection. And here another example where the blood vessel just fades out and you have the complete occlusion at the typical location for dissection, i.e. where the mobile segment of the ICA enters into the immobile segment within the petrous portion. This is where you have the highest shearing stress in rotational and hyperextension type injury. And this is where you will see your mural hematoma. This is how you can make the diagnosis of a dissection. Here we have a young patient who presented with multifocal embolic strokes in the thalamus and within the pons. And in these areas, you'll have to look for a dissection flap. You can see very nicely here the dissection flap or the mural hematoma in this example. What are the false positives of dissection? In this case here, the time of flight MR angiography looked as if we had bilaterally high degree stenosis or dissections, But when we look at the technique that was used, this was done with a so-called water excitation-based time-of-flight MRA as compared to your standard time-of-flight MRA. And the water excitation time-of-flight MRA is very susceptible to air and bone interfaces, i.e. to susceptibility artifacts. And these susceptibility artifacts can be so strong that they take out the signal of the ICA, and therefore you have to look very careful at the type of time-of-flight MRA that you are doing at your local scanner. And this is especially true if a patient has now, for example, a unilateral sinusitis. Look at this patient. It looks as if he had a right-sided stenosis on this water-excited time-of-flight MRA. But now if you look at the sinuses, you see that on the left side, there is a sinusitis. Therefore, the water-excited time-of-flight MRA did have its susceptibility artifacts on the right, but no susceptibility artifacts on the left, and therefore it appears that the patient has a unilateral stenosis. Remember these artifacts. What about this patient? Does this patient have a huge dissection with a dissecting flap here? Well, know your anatomy. If you know the anatomy, then you know that you can have so-called duplications or fenestrations of the vertebral artery at this level here. And this is nothing but an anatomical variation of normal. Same holds true here. This is not a clot within the M1, but this is a fenestrated MCA. And this is not a clot in the basilar artery, but a locally unfused basilar artery that is related to the fact that during embryological development, your paired ventral longitudinal neural arteries fuse to form the unfused basilar artery. And if this fusion process is incomplete, then you have a local non-fusion that in this case can look like a dissection or a thrombus. What are other false positives? In this patient here, we thought that there may be a dissection within the right vertebral artery. However, if you look very carefully, this is just a hypoplastic vertebral artery after the origin of a dominant pica artery. So this is a normal anatomical variation. What are the false negatives of dissection? We see in this patient that we have what looks like a hypoplastic left vertebral artery. But if you look very carefully, the vertebral artery is not looking happy right there. And then if you're using your fat-suppressed T1 weighted sequences, you can see the T1 hyper signal within the vertebral artery related to this acute dissection within the vertebral artery. What about this patient? On time of flight, this patient looks as if he had very nice flow within both carotid arteries. And most of you would say that this time of flight MRA is completely normal. However, in the same patient, a contrast enhanced MRA was performed that demonstrated no flow whatsoever in the left ICA. This is the same patient. Which technique is wrong? Is it the contrast enhanced MRA that demonstrates the missing vessel, or is it your time of flight MRA? And now remember that the time of flight MRA is intrinsically T1 weighted, which means that if you have a primary T1 hyperintense thrombus within the ICA, it may show up because of its T1 effect, not because of its time of flight effect. And in this case, there was acute thrombus within the entire ICA, as visualized on this non-enhanced T1 weighted sequence that looked bright on the time of flight MRA. So remember that an entirely thrombosed ICA has a short T1 and may not be distinguishable from flow, and therefore always look at your anatomic sequences in addition to your time of flight technique. Here, another false negative. This was a patient where we said looks pretty normal, but there's unfortunately right here a significant metal streak artifact present. And this happened to be present right exactly where the patient had a focal dissection. That could also be visualized here on these sequences that clearly demonstrate that the vertebral artery was dissected at this level, and we simply didn't see it because of the artifacts. So your caveats of dissections are here false positives as well as false negatives. Our imaging protocol, we strongly do believe in T1 fat suppressed imaging, time of flight with a saturation band or with vessel wall imaging. And here's just a recent example of a patient with a dissection that we could see very nicely here on the unenhanced black blood imaging sequences, on unenhanced T1 weighted sequences. And here another example of a dissection where vessel wall imaging shows the spiraling dissection. And here another example of a dissection where vessel wall imaging demonstrates the methemoglobin signal in this apparent narrowing of the MCA in this young child. In this example here, you see that again, the T1 methemoglobin signal can look as if there was a normal signal here, and you can find out whether this is true or not by doing double saturation bands that will saturate all the flow but will not saturate the T1 effect. We discussed about some of the diseases here. Now I will go into specific consideration of childhood stroke. And one of these specific considerations is that you have to not only in the pediatric age group look at the brain, but you also have to look at the heart. In this patient here, we saw on EKG-gated cardiac imaging a focal thrombus present within the wall. And by using now intelligent contrast agent as a fibrin-specific contrast agent, you can identify that this is indeed an acute clot that is sitting in the left ventricle, waiting to fly up to cause another stroke. You'll have to think about HHT in patients with stroke. As in HHT, spontaneous recurrent nosebleeds can present, but patients can also present with paradoxical emboli. Then you, if you could actually take out those things here, this is not me, that would be great. I don't know, someone is painting on my pictures here. So maybe if you could erase this, that would be great. Otherwise, we can also continue. We have here a 10-year-old patient who presented with hemianopia. And if you have additional symptoms such as cardiomyopathy and gastrointestinal symptoms, then you have to think about melas, especially if in the acute phase there's a very hyperintense signal that is not within an arterial territory, but is crossing different arterial territories. If you then perform a spectroscopy on the contralateral side that demonstrates a lactate peak, you know that this patient has the diagnosis of melas. For the sake of time, I think, and because our main topic is actually ischemic stroke, I will briefly, I think I will skip the hemorrhagic stroke component of this talk, as this is, I think, going now too deep into the hemorrhagic stroke, which I believe we can do for another session if we want to speak, or if you are interested to hear about pediatric vascular malformation or pediatric aneurysm, as this is, like as you can see here, a very wide field. And rather than now going into the hemorrhagic stroke, I would like to briefly talk a little bit about intervention in pediatric stroke And if then there is still a time, I will go into some cases. Intervention in ischemic stroke is a team effort, and we are very happy to have a great group at SickKids that is performing this type of intervention in acute stroke. Yes.
Please carry on, sir.
Sorry.
Let's go ahead.
Please.
For sure. So when we talk about the technique and the approach and judgments for ischemic stroke in intervention in adults, it's a pretty simple approach, and there are only very few questions that are left unanswered. However, in children, everything is a technical question, from establishing the diagnosis to prognostication of natural history to choosing the imaging to medical system challenging and all the adult technical questions. So therefore, rather than like going into like a full-blown frontal lecture, I would like to show you a couple of cases of ischemic stroke and how we dealt with them at the SickKids Hospital. So here we had an 8-year-old girl who had pulmonary hypertension. She was awaiting lung transplantation, and she was on ECMO, transitioned to an excorporeal lung assist device. And although she was on ultrafractionated heparin, multiple strokes formed. 2 weeks later, following her initial presentation, she had this stroke here with an acute clot. The CTA was completed relatively fast simply because we knew that she was hypocoagulable, and therefore it was quite easy that we were able to get in, we saw the clot, we put in a stent retriever, we took the clot out, and the patient was absolutely asymptomatic. This is the clot that we took out. Now, believe it or not, just a couple of days later, the patient presented with a new stroke. And again, there was clot right there. And we went up and again were able to take out the clot. And this time, we actually imaged the device and saw that within the device, there was a clot forming. And so we had to exchange the entire tubing. We took out the clot out of the tubing. The patient underwent a lung transplant. It is now absolutely fine. So the teaching point for this patient is that if you have a patient with an extracorporeal circulation, they are at a high risk of developing stroke. And in these cases, we do perform stroke thrombectomy. And remember to also image your extracorporeal circulation. Here, we had a patient who liked to crack his head, and during one of these procedures, he developed with acute onset of dizziness and unsteady gait. Imaging demonstrated an already established ischemia, and so we were not sure whether we should actually go ahead and treat the patient. However, what we saw on imaging was that in this case here, the lesion was way more significant than the area of ischemia. So we believed that this patient may benefit from us taking the clot out, because we believe that due to a focal dissection with a clot waiting to go up, the patient may deteriorate it. And while we were discussing with the family, with the stroke team who were lukewarm to our idea, the patient suddenly deteriorated and now presented with even more so an occlusion of now the entire basilar artery. And of course, at this moment, we went in, we took out the clot, which went very nicely. The vessel got completely reopened, and the patient did significantly better. So the case teaching point here is that if you have a patient with a dissection, and if there's clot that is waiting to go up there, don't wait to take out the clot. Then we have this patient here who presented after having had a roller coaster day where she went on a roller coaster with significant G forces multiple times. She developed with an acute PCA territory infarct. The teaching point here is look at the clinical symptoms. She presented with vomiting first and foremost. And therefore, the diagnosis was only made way too late when the ischemia was already established. And this was the roller coaster that she went on to. Remember that repeated microtraumata can lead to dissection of the intracranial vessels. In this case, we saw a dissection that had led to a complete occlusion of the vessel. And remember that the dissections are very like much changing over time. And in this case, after 1 week, the dissection completely reopened. And now the patient was at a risk of hemorrhage. And in these cases, you therefore have to think about occluding the blood vessel, which is what we did in this case here. So the teaching point here is sometimes parent vessel occlusion is what you have to do in patients with acute stroke, although it seems counterintuitive. And just to drive home this point, here's another example who had a seatbelt injury, developed a stroke in the morning. The patient came in, and what we could see here is that the patient had a dissection here with a lot of clot within the entire ICA and a focal clot within the MCA. So she was at risk of leading to a complete infarction of her entire hemisphere. So what I did in this patient is I went past the dissection, I removed the distal clot, but then I said to myself, if I now pull back my microcatheter, the clot that is in the ICA is just waiting to go up. So I punctured the other side. I saw that the patient had a very good ACOM, and I therefore decided to completely obliterate and completely occlude the right-sided common carotid artery to prevent clot from going up. So I put in coils from here to here. The patient had excellent collateralization, had no symptoms at all, and the clot that would have just waited to go up and make another stroke could not go up here. And this was the right choice in this patient. And actually, she did very well on exam. So these are the teaching points in this case here. And when we look at the literature of intervention in the pediatric population, there are very few case reports out there, but it is our belief that for certain patients, it does make sense to go after the clot, even in the pediatric age group. And these are the techniques that I am classically using. So consider the natural history, and we definitely are in favor of treating these patients. Now, shall we go through some cases? I know it's 12 o'clock and or here in Toronto, so I spoke now for nearly 1 hour. My question to you is, shall we go for more cases, or do you want to stop here and I will give those cases at a different point in time to also have enough time for the other lecturers to give their presentations?
Thank you very much, sir. Professor Chaudhary, how do you feel?
I think we should wait a little bit because Dr. Prabhu he has also got another meeting. So his presentation is about 20 minutes. So after that, Dr. Krings, he is most welcome. And I can take my presentation at the end. For me, no problem. So let us listen to Dr. Shujit and Dr. Krings. What you want to do? We are always welcoming you, but maybe 20 minutes for Dr. Shujit Prabhu. What do you think?
I have a proposal in between. I sincerely want Professor Timoping to give one more lecture for us in pediatric and professions next month or something. That would be very good for us.
I'm very happy to do so at any point in time, but maybe now, because Dr. Chudori also has a meeting to go to, I will briefly stop sharing and we can listen to his talk.
So I hereby request Professor J.D. Chaudhary to have a brief introduction of Professor Sujit Prabhu before his talk. Professor Chaudhary, please.
Dr. Prince, can you please unshare your screen, please? Dr. Prince, can you please unshare your screen because we can see your screen?
I think this is the screen of Professor Sujit Prabhu.
Can you share?
Oh, this is the screen of Dr. Sujit. Okay, let me present Dr. Sujit Prabhu. He is a professor of neurosurgery at MD Anderson Cancer Center in Houston, Texas. He graduated from Medical College of Ballery, and he's also a fellow of Royal College of Surgeons in Edinburgh. He completed his neurosurgery residency at Medical College of Virginia in Richmond, Virginia, and fellowship in neuro-oncology at MD Anderson Center. He has advanced the field of brain mapping and awake brain surgery. He is an experienced user of intraoperative MRI and has been a major contributor in this field. He is also a pioneer of a number of technologies, including laser interstitial thermal therapy for deep-seated brain tumors. So before we start his presentation, let me show a small video clip. Dr. Sujit has already in the YouTube. So I would like to show his video clip. Dr. Sujit, can you please unshare your screen so that I can show your small video clip? Okay, good.
Are you willing to play guitar during the resection? He looked at me and I think there was a kind of stunned silence.
Kind of like, what does everyone gonna think when I'm jamming? Okay, I play electric guitar, I love metal. I don't know very many acoustic songs, very nice songs.
I could see that he wanted to preserve that function. It meant a lot to him, especially his ability to sing, recall, his memory, his motor functions or dexterity, which is critical. In my mind, I said this would be the perfect case where we can test a lot of these functions. We are really on that path where we're going to personalize, the type of testing we do in the operating room. I think patients demand that.
They asked me if I wanted to play guitar, handed me the guitar. Of course, I said, yeah, of course, pass me the guitar. I played Creep from Radiohead.
The brain actually has no pain fibers. It has no sensation. And when you combine that with the fact that we can apply regional anesthesia, numbing medicine to strategic portions of the brain, and you can numb up the skin, the muscle, and the bone, it makes for a remarkably comfortable surgery.
Everything just worked like a symphony. Everything just seemed to flow. I don't think there's a single part of the brain which controls music. When I think of music in general, I've used the word passion, but it comes from the heart.
picking up the guitar just feels like Thor picking up his hammer. I want to put it in the air and let the lightning strike it, you know? But I'm
So, Dr. Sujit Prabhu, please, we welcome Dr. Sujit Prabhu. Please present your case, please.
Thank you, Professor Zia Chowdhury. Can you guys hear me?
Yes,
can you hear
sir.
me?
I can hear you.
Okay, thank you. Can you see my screen?
Yes, we do. Yes, sir.
All right. Just to switch gears, I'll be talking today about a technology which some of you might be familiar with. It's called laser interstitial thermal therapy for treatment of brain metastases and radiation necrosis as it relates to the treatment of brain metastases. My outline would be a few slides on radiation necrosis. For most of you are familiar, there's an increasing incidence of radiation necrosis following stereotactic radiosurgery and or immunotherapy. And we've come up with a management algorithm in suspected cases of radiation necrosis. I'll present a small case series. Some of the slides are provided by Dr. Jing Lee, who is our radiation oncologist here at MD Anderson Cancer Center. As a slide of introduction, the pros of stereotactic radiosurgery, which will include things like gamma knife, LINAC-based surgery. The whole idea is to spare normal brain function. Clearly, it has a high control rate, treats lesions which are not surgically accessible, and patients leave the same day of the procedure. And there's really minimal break in systemic therapy, which means patients can continue with their systemic therapy as part of the treatment. Now, the cons, clearly it's not available in many centers. It does not treat microscopic disease when we compare it to whole brain radiation. There are limits for the number of lesions which can be treated. And clearly, some of the structures like optic chiasm, brainstem, so on and so forth, which clearly due care has to be taken prior to these treatments. So when we think of brain metastases and the role of stereotactic radiation and whole brain radiation, which is still used widely, MD Anderson was really a pioneer in this phase 3 randomized study to look at the quality of life following stereotactic radiosurgery when compared to whole brain radiation therapy. And this paper was published in 2009. This is a paper by Chang. And clearly the conclusion was whole brain radiation therapy improved local control, but clearly there was significant cognition impairment of patients seen at 4 months. So clearly there was a concern with using whole brain therapy in patients with 1 to 3 brain metastases. And then this other landmark study, which was part of a multi-institutional study, which was a phase 3 randomized study conducted by Paul Brown, which was published in JAMA 2016. Again, it focused on the same question using randomized patients to either stereotactic radiation versus whole brain radiation. And clearly, there was worse cognitive decline, as you can see these numbers in patients who were treated with whole brain radiation. A slide from Dr. Lee. This is unpublished data. Again, we looked at stereotactic radiation therapy for 4 plus brain metastases. This will be published or actually published soon. Again, the endpoint was to look at cognitive scores at 4 months. And the patients were randomized to either whole brain radiation versus stereotactic radiation. And you can see there are a number of metastases that could be treated. And as you can see from the results that stereotactic radiosurgery clearly helped in preserving cognitive function. However, if you look at the median overall survival versus local control in both stereotactic radiation and whole brain radiation, the p-values were not significant. Again, the whole point here is to make a pitch that cognition is very critical in preserving that function, especially in terms of patients with radiation and systemic and metastatic cancer. So what about radiation therapy for post-surgical resection? And these were two studies. One on the left was published by MD Anderson. This was published by Mahajan et al. In Lancet Oncology in 2017. This was a phase 3 study to basically look at the advantage of stereotactic radiosurgery versus observation in post-resection metastases. And the endpoint was local control. And you can see on this graph, there was a very significant spread of these curves in patients who had observation versus stereotactic radiation. And this was then duplicated in another study by Paul Brown, where he asked the same question. The primary endpoint was neurocognitive function, also showing that stereotactic radiosurgery was superior to whole brain radiation therapy in local control, as well as improving neurocognitive function. So what about combining radiation therapy and immunotherapy? So as we know, radiation promotes tumor antigen release and other aspects of T-cell mediated immune response. And it turns tumor into an active vivo vaccine. And that is a well thought of concept in among the radiation field, And as we know, immunotherapy enhances the radiation therapy abscopal effect, turns the radiation therapy from a local therapy into a systemic therapy because of the release of these various immune response antigens. And it can reverse some of the immunosuppressive effects of radiation. This was a paper which was published from the group at MD Anderson, showing the increased risk of radiation necrosis as we combine stereotactic radiation with immunotherapy. So we at MD Anderson have put together an algorithm where we have these multidisciplinary meetings which are held weekly. They consist of neurosurgeons, radiation oncologists, neuroradiologists. We review a large number of cases, and the cases which eventually fail radiation have to be decided in terms of the protocol into which they fall in. So typically when we see patients with radiation necrosis, we initial steroid treatments are given. If they fail those treatments, and we look at least 2 to 3 separate scans over a period of 3 to 6 months. If there's a failure of that treatment, then we do what we call advanced brain tumor imaging, consisting of the DCE, DSC, and MR spectroscopy. Some of you are probably familiar with this technology, and in some cases, delayed PET. And then once that is established, we have an arm of patients who might get Avastin. Clearly, laser interstitial thermotherapy is used very frequently in our center, and I will talk a little more about this technology. So I will jump into the case series which are mostly cases of mine. I've got a couple of cases from our radiation oncologist. Just to give you a sense of the technique, we use a system called the Monteris NeuroBlade system. Once we make a opening in the skull, we implant these holes through which the laser fiber is passed. And as you can see on this this video, this is a laser probe, which can fire at an angle, which we call a side fire laser. We also have a laser probe which can deliver the laser activity in a spherical manner. So clearly there are different opportunities to treat the different type of tumor, because all are not in a sphere. They can have different aspects to their shape. So I'll start with this case one. This is a 35-year-old patient with a metastatic melanoma treated with stereotactic radiosurgery for the brainstem. And as you can see, there are dates at the bottom of the scans, and these are axial images, post-contrast. You can see there's the patient presented with this metastases, had stereotactic radiation therapy. 6 weeks later, there was at least some stability, but look at the scan at 3 months. There's clearly some enlargement. Some of that could be blood. It continued to evolve, but then the patient had what we call dexamethasone, which is steroids, and we saw some improvement. And it was probably the time lag, but clearly this continued to improve, and this is the most recent scan. And you can see now there's a durable response at least a year. The reason I put this slide is it shows the value of using dexamethasone or steroids in cases where obviously other interventions might be difficult. So this is another case, a 67-year-old patient with metastatic breast carcinoma, which the progression following stereotactic radiation. There are a couple of slides here, one showing the actual lesion. This is posterior left frontal lesion. In this case, we did the laser interstitial thermal therapy. The patient did not want a surgical resection because some of the surgeons out there might say, why cannot this be resected? Which we did offer to the patient. In this case, the biopsy was consistent with a metastatic carcinoma. And this is the images we get intraoperatively. We get a DCE image. Most of these cases, in fact, all the cases are done in our intraoperative MRI scan or suite. And you can see we got a good coverage of the lesion following the laser treatment. This was done after the procedure. I would like to bring to your attention a little blip here. You can see these little areas in the anterior aspect of the cavity where you see some increased blood flow. And we followed that area after treatment. This is a post-treatment scan after a month. You can see this area, which we thought was probably not covered, continued to evolve. And what was interesting with this area, or particular area, was it was adjacent to a sulcus. And one thing with a drawback with laser interstitial thermal therapy is there can be what we call the amount of heat as it approaches a fluid space can be discharged into the fluid space, thus creating an environment where the kill related to the heat may not be that significant. And that may be the situation here. You can see the scans subsequent to this scan showed evolving mass. So clearly the rest of the mass got very good benefit, and that prompted a surgical resection. So we went back and resected that small component of the mass. This is another example of a 60-year-old female with metastatic breast carcinoma to the cerebellum. Again, this is a deep left cerebellar mass showing on the DSC scans some variable blood flow, a lot of edema in the posterior fossa. This is a scan from 2016. This was our approach. We do this frequently in the posterior fossa, and this is an immediate DSC scan showing a good treatment result. Again, in this case, the pathology was consistent with tumor along with necrosis, and you can see these scans are now 2 years after treatment with very stable appearing lesion. So this is clearly a small lesion which was significantly benefited following laser interstitial thermal therapy. I showed the scan, which is a 64-year-old patient with a parasagittal meningioma. We have used it for other types of tumors, and in this particular case, this patient was treated elsewhere at an outside hospital for this small lesion in 2015, which was watched. It grew to be this size in a year, which is 2016, and in 2017 she was treated. At this point, she was treated with radiation. This was at an outside institution. This was a staged treatment. I believe she had 3 to 5 courses of focal radiation, and unfortunately developed this area of necrosis on her scans in August of 2017. We then treated her focally with laser interstitial thermal therapy. We took a left parietal approach. As you can see, the DSC images clearly show some good treatment effect there. The scan on the right side is a subtraction image. I get this on all patients pre and post contrast imaging scans done in the intraoperative MR. And this margin gives us a sense of the extent of treatment, which mirrors what we see on the DCE scan. And in this particular case, we get biopsies on all these patients, clearly showing extensive necrotizing treatment, and clearly this was meningioma, which was treated. This is another case, obviously the same case. I'm sorry, this is 2 years after the treatment. You can see a very nice response to laser interstitial thermal therapy to radiation necrosis. In fact, this is the most recent scan. So you can see we've got an excellent result 2 years after treatment. This is another case, a patient who, hello? This is another case, a 60-year-old with metastatic renal cell carcinoma who failed stereotactic radiation. Again, a deep cerebellar mass. These are scans from 2018 through to 2020, showing a very good response. This is a shell of the former tumor. You can see this is an immediate post-op scan done in the brain suite. And you can notice that there is slight enlargement of what the mass would be. And that is not uncommon. Sometimes we see some associated edema related to this, which can be treated with steroids. And again, just to show the edema pattern significantly improves after this treatment. Obviously, it is time dependent, but in most cases, we see a very nice reduction in the amount of edema you see on these scans. So my last case would be a case of a 69-year-old with a papillary thyroid carcinoma. This is a gentleman who came to us in the early part of 2018 with this mass. And I did resect this mass, had a good result, but then it recurred locally. You can see within 6 months after the resection, it recurred locally, it continued to progress. And this is what we treated with laser interstitial thermal therapy. In fact, when we resected the tumor, we did not find any viable tumor. I just got to mention that after the resection, the patient did receive stereotactic radiation therapy to the tumor bed. And now he's had a good result. This is his most recent scan with no recurrence. So when we think of the role of laser interstitial thermal therapy, this is a paper which we published from our group a couple of years ago, which was published in Neurosurgery, showing, looking at predictors for local control of brain metastases. And we had 82 tumor types at the time. You can see the breakdown of the different pathologies. This becomes relevant as we go along the presentation because some of the tumors were dural-based, some were not. And then prior to using the Monterey system, we did have the visual A system. So that's the difference in these two lit systems. We now use exclusively the Monterey system. Now, when we think of ablation, the reason I break this up into a complete and incomplete ablation is sometimes we cannot get the margins of the tumor completely encaged or enveloped by the laser treatments. And that could be for a number of reasons, including the depth of the tumor, the location, the geometry of the tumor, et cetera. But in that case, a large number of patients had a complete ablation. And as you can see, when we looked at patients who had a complete ablation versus an incomplete ablation or a not perfect ablation, you can see there's a difference in their survival. Okay, so that becomes very important in completing or doing a complete ablation. When we look at tumor volumes, and we've treated tumor volumes, large tumors, but when we looked at tumor volumes in terms of patients who had tumor in excess of 6 centimeters in size, which computes to, or 6 centimeter cubic centimeter volume, you can see the size is close to 2 centimeters. So it's not a large tumor, but clearly a good sized volume of the tumor. And when we broke that down, patients with a larger tumor volume clearly had, or a smaller tumor volume did better than patients with a larger tumor volume. So that becomes important as we plan treatments. Again, going to the dural-based versus non-dural-based, that becomes relevant because the dura is obviously a fibrous, we think of it as a fibrous structure, a lot of collagen. The heat spread through these tissues is not as significant as what we think in brain. And also the CSF acts as a barrier in terms of what we call heat sinks. So clearly dural-based lesions do not fare as well. And then when we looked at patients who had recurrent tumors in their lesion versus purely radiation necrosis, the patients with radiation necrosis did a lot better than patients who had recurrent tumor in their specimen. And one very interesting aspect of our results was the role of systemic therapy. This has not been shown in many studies, the role of laser interstitial thermal therapy and its relevance to systemic therapy. When we looked at patients who had systemic therapy before and after treatment of laser interstitial therapy, because laser interstitial therapy opens up the blood-brain barrier and facilitates the passage of systemic treatments or chemotherapy, we can see patients who had systemic therapy before LIT or even after LIT had a better survival. So clearly we want to advance systemic therapies in patients after LIT, and I've been a big proponent of using systemic therapy as soon as possible because most of these patients can be given treatments even 24, 48 hours after laser interstitial thermal therapy. And so when we looked at the variables which really reached significance in terms of using a multivariate Cox regression model, patients who had systemic therapy, dural-based tumors, and the LIT indication reached significance, as you can see on this model. Again, being a very minimally invasive procedure, the complication rates are low. We had 2 patients with sustained permanent neurological deficits. One patient had a displaced probe after placement, which was more of an MRI technical issue. And unfortunately, we did have one death from pulmonary cerebral edema. So we recently published this paper in Cancer Letters. This is a good read for anyone who's interested in this technique. And this is more of a comprehensive review of the data as well as some of our own data. And this is taken from the paper showing an example of how this is done. The technique itself, we use 3D brain modeling techniques to identify the corticospinal tracts. We can use it to model the fiber tracts to preserve function. In this particular case, if you look at this particular image here, there are concentric lines around the tumor, and this is what we see intraoperatively. We want to achieve complete ablation by the blue line. You can see the blue line here, which pretty much envelopes the entire mass. And so if we get the blue line to go beyond the margins of enhancement, then we've achieved a complete ablation. And usually the yellow line, which is obviously the line after the blue line, is also important because the importance of the yellow line is the tissue interface between the yellow line and normal brain portends recovery of tissue, but whatever is within the blue line is really dead tissue, and there's no hope for any recovery within that area. So again, going back to the decision tree, this is a multidisciplinary approach which we conduct every week. And like I mentioned, after review of the cases, patients are given steroids for at least a couple of, for 2 consecutive MR scans. If there's a consensus that the patient needs laser interstitial thermal therapy, the MR features are discussed. We do additional advanced brain tumor imaging, and then the laser interstitial therapy. So with that, I think I have concluded my talk. I'll be happy to take any questions, but thank you very much.
Thank you, sir. Thank you very much. It is a new technology, but it's very much essential for all neurosurgeons to know about. Now we'll move on to our last talk of today's webinar. I'll be requesting Professor J.D. Chaudhuri for his talk. Dr. Chaudhuri is of radiology and ex-chairman of radiology and medical imaging and advancement regional hospital in Canada. He is a clinical professor of diagnostic radiology at the University of Sheffield. His current interest includes artificial intelligence, deep learning, and augmented reality in the field of medical imaging. Professor Chaudhuri, please.
Thank
and
you very
if we
much.
have time, we'll take questions after this.
Thank you very much for a kind introduction. I want to share my screen. Do you see my screen?
Yes, sir, we can see.
Okay. So today my presentation will be a little bit different, and it's funny. The interpretation of any radiological image needs a clear understanding of the semiology. In the following 25 to 30 minutes, I'll be discussing a number of animal-inspired radiological signs. These signs are easily recognizable and highly memorable. Here in this slide, we can see 3 different paintings. The first one is Mona Lisa of Leonardo da Vinci. The second one is the Sunflower of Vincent van Gogh. And the last one is the famous Water Lily of Claude Monet. Possibly you have already seen those. It is relatively easy to enjoy the beauty of those paintings right from the first glance. But there are times when it's not so easy to enjoy the quality of painting from the simple look. Again, here you can see 3 different paintings. The middle one, for example, is Metamorphosis of Narcissus by Salvador Dali, who, by the way, is my most favorite artist. It's not that easy to extract the pleasure and amusement without a brainstorm. The theme of those special type of paintings come from surrealism. To enjoy those, you need a creative imagination. Day in and day out, the radiologists browse through thousands of images. Basically, all radiologists, we are philosophers, and we have a lot of fantasy. We try to stitch all our phantasm with the clinical context in order to reach a diagnosis. Our inspiration may come from anything, even from the food we take every day. For example, apple core lesion in colon cancer, croissant sign in subdural hemorrhage, coffee bean sign in sigmoid volvulus, etc. Sometimes they can even be animal inspired. In today's presentation, I'll walk you through a few of the animal inspired radiological signs. So let's move on. This young patient presented with ataxia, cerebellar syndrome, and signs of increased intracranial pressure. The patient also had multiple skin lesions, possibly a component of Cowden's disease. And here is the MRI. In T2, we can see unilateral, non-enhancing cerebellar lesion. And there is displacement of the fourth ventricle from the mass effect. The lesion appeared to be consisting of alternate bands of hyper and isointensities representing cerebellar folias. This gives the typical zebra appearance in our imagination. So it is known as zebra sign. The zebra sign in MRI is typically seen in Lermite-Duclos disease. This is also a zebra sign, but in CT scan. This is a non-contrast CT scan at day 4 in a patient who underwent uncomplicated craniotomy. It shows stripes of cerebellar folia bilaterally. It is due to the presence of high-density fresh blood in the subarachnoid space. Following the surgery, the patient was also slow to recover. This is due to the remote cerebellar hemorrhage. Remote cerebellar hemorrhage is a rare but benign complication of supratentorial craniotomies. Initially, the patient had mild gait disturbances, but returned to normal after 4 months. MRI after 3 months shows bilateral superficial siderosis on the folial surface. The exact cause of remote cerebellar hemorrhage is not known. This cancer patient presented with headache and seizure with altered mental status. MRI shows a round intraparenchymal space-occupying lesion with central necrosis at the right parietal lobe. There is moderate perilesional edema and intense peripheral ring enhancement at gray-white matter junction. The central necrotic region showed low signal in T1 and there is thick peripheral enhancement. This metastatic lesion resembles a bullseye, so it is known as bullseye sign. Some of our colleagues also call it as target sign. Bullseye sign is not specific for brain metastasis. It can also be seen in other conditions like brain abscess, primary brain tumor, regressing hematoma, etc. This is another bullseye lesion representing a brain abscess as complication of chronic suppurative otitis media. The peripheral rim is isointense in both T1 and T2, showing a smooth and regular wall. The interpretation must be in the clinical context. We can also see moderate perilesional edema. But in regressing hematoma, there is no or very little perilesional edema, especially in subacute setting. Again, it has to be interpreted in specific clinical context. This HIV-positive patient presented with acute confusional syndrome and high fever. Post-contrast MRI showing multiple eccentric bullseyes. There are 3 alternate zones. The innermost zone is enhancing and eccentric. It represents the inflamed blood vessel. The peripheral zone is also enhancing, representing the capsule. The tissue in between is hypointense and it represents the necrotic contingent. This eccentric bullseye sign is pathognomonic for cerebral toxoplasmosis, again in clinical context. This sign is 95% specific and 25% sensitive in cerebral toxoplasmosis. In cerebral toxoplasmosis, once in a while, the bullseye can also be concentric appearance. And when the lesions are concentric, it is difficult to differentiate from concentric lesions of Bellow. That is the Bellow's concentric demyelination. However, the bullseye sign in cerebral toxoplasmosis, there is marked perilesional edema, as you can see here. In Bellow's concentric sclerosis, on the other hand, there is no significant perilesional edema. This patient is suffering from Wilson's disease. There is bilateral Kaiser-Fleischer ring. MRI shows T2 high signal abnormality in the tegmentum, and due to increased iron content, both the red nuclei and substantia nigra stands out very prominently, surrounded by high signal white matter. In the fantasy of the radiologist, it looks like giant panda. Giant panda sign is not specific for Wilson's disease. The findings can also be seen in other diseases like Japanese encephalitis. The findings need to be correlated with other clinical biological profile. This patient presenting with confusion and gradual intellectual decline. He is a recreational drug abuser. He was diagnosed as a case of chasing the dragon syndrome. Chasing the dragon is a Hong Kong slang for vapor inhalation. Pathologically, it is a form of spongiform encephalopathy. It is from inhalation of drugs like morphine, cocaine, heroin, and yaba, etc. The very culture of drug inhalation started from the panic of HIV transmission through the needles. So the abusers started inhaling the drug rather than injecting themselves. They usually wrap the heroin in aluminum foil and then burn it. When the drug is heated, it becomes soft and gelatinous. And ultimately, a fiery smoke comes out which resembles the tail of a dragon. They inhale the smoke from that tailing end. The MRI shows bilateral high signal at the cerebellar hemisphere. In CT scan, the lesion appears as hypodense lesion bilaterally. These cerebral findings looks like head of lion, and it is known as head of a lion sign. These are T2 images of dural cul-de-sac. We know the spinal cord terminates at D12 and L1, or maximum at L1, L2. The spinal nerves originating from the spinal cord continues to travel further below in the thecal sac before they exit through the corresponding vertebral foramen. They take a vertical course. The collective image of the spinal nerve in the thecal sac resembles the tail of a horse, and radiologists call it as coda equina, and it is a normal finding. The first image is the normal coronal slice in T1. Anatomically, the hippocampus is forming the medial wall of the anterior pole of the temporal horn. In normal healthy individual, the anterior pole of the temporal horns are not seen. And when the brain atrophies, the hippocampus also shrinks. The ventricular dilatation coupled with hippocampal atrophy causes the visibility of the temporal horn, as you can see here in the second image. This can either be from age-related atrophy or Alzheimer's disease or whatever. This time, can I say that the hippocampus looks like a trunk of an elephant? So it will not be unwise to describe the finding as elephant trunk sign. This sign can also be seen in mesial temporal sclerosis. However, in mesial temporal sclerosis, there is signal change of the hippocampus. There is another elephant trunk sign in plain X-ray. This sign helps both the radiologist and traumatologist to verify the integrity of the temporal process of the zygomatic bone following trauma. In plain X-ray, the temporal process of the zygomatic bone has also an elephant trunk configuration. This patient was treated aggressively for rapid correction of hyponatremia. The axial T2 images showing the findings compatible with central pontine myelinosis. The transverse pontine fibers appear as high signal with preservation of corticospinal tract and tegmentum without any mass effect. These findings resemble snout of a pig or the face of an owl. In radiology literature, it has been described as piglet sign or owl sign. The corticospinal tracts representing the nostrils of the pig or eye of the owl. Central pontine myelinosis is an iatrogenic non-inflammatory demyelinating disease. The rapid change in serum osmolarity is believed to cause disruption of the blood-brain barrier. It leads to retention of hypertonic fluid in the extracellular space. However, it's not clear why the pulse is preferentially involved. There can also be extrapontine myelinosis in advanced cases. This is the normal axial image of substantia nigra at the level of the midbrain. Due to high iron content, it appears as low signal. However, the dopamine-producing nigrosome cells in the posterior third of the substantia nigra appear as linear high signal band. The linear area is surrounded anteriorly, laterally, and medially by normal signal of substantia nigra. This is the reason why the normal substantia nigra resembles splitted tail of a swallow. The next image is a patient with Parkinson's disease presenting with tremor and bradycardia. In the right side, we can see the normal swallowtail. In the left side, the swallowtail is missing due to the decreased signal from nigrosome. Missing swallowtail sign is a very important finding in Parkinson's disease. It has a negative predictive value of about 90%. This child presented with learning difficulties, aggressive behavior, and impaired adrenal function. The patient was diagnosed as a case of adrenoleukodystrophy. The first two images showing retrotragonal T2 and FLAIR high signal due to dysmyelination, and the area are interconnected through splenium of the corpus callosum. The next post-contrast image showing the peripheral linear enhancement, which outlines the contour of the involved area. This specific finding resembles the inverted wings of a bat and has been described as inverted bat sign in radiologic literature. Pelizaeus-Merzbacher disease is a rare congenital disorder, and pathologically it is a hypomyelinating disease. MRI in this patient with Pelizaeus-Merzbacher disease showing hyperintense linear stripes within the bright demyelinated white matter in T2 at centrum semiovale and periventricular region. It looks like the stripes of the skin of a tiger. The radiologists love to call this image as tigroid sign. Tigroid sign can also be seen in other conditions like metachromatic leukodystrophy and Charlevoix-Séguin syndrome. This CT scan shows bilateral intraparenchymal space occupying lesion. It has both solid and cystic component. The lesion is involving the genu of the corpus callosum, and it causes extrinsic compression on the ventricular system. Based on the configuration of the lesion, it has been described as a butterfly lesion. Butterfly sign typically contraindicate the surgical option of the tumor. Butterfly lesion can also involve the splenium of the corpus callosum. The CT scan here showing an ill-defined non-homogeneous hypodense lesion, and MRI after gadolinium showing the thick and irregular periphery. Also, you can see both the solid and cystic contingent of this lesion. This FLAIR image showing abnormal cone-shaped hyperintensities extending from the tip of the frontal horn in the region of forceps minor. It resembles the tuft of hair crowning the ears of a lynx. So it is known as ears of a lynx sign. MRI sign is generally seen in hereditary spastic paraplegia. This patient presented with seizure disorders. MRI reveals corpus callosum agenesis, T2 coronal slices showing slightly dilated third ventricle and increased distance between the diverging frontal horns. These findings resemble head of a toro, better seen in enlarged view, and has been described as toro sign. This is a patient of pseudotumoral multiple sclerosis in active phase. The white matter lesions are giant with scanty and disproportionate perilesional edema. Post-contrast images reveal incomplete ring enhancement. This finding resembles the impression of a horseshoe, and this is known as horseshoe sign. Horseshoe enhancement can also be seen in acute disseminated encephalomyelitis. The enhancement is always at the white matter side of the lesion. It represents advancing side of demyelination. This patient is showing bilateral symmetric high signal inside globus pallidus. It is surrounded by increased iron-containing brain tissue. The central high signal is due to gliosis, increased water content, and neuronal loss. This particular image resembles eye of a tiger and known as eye of the tiger sign. This appearance is common but not pathognomonic for Hallervorden-Spatz disease. It can also be seen in Steele-Richardson syndrome or progressive supranuclear palsy, multisystem atrophy, Wilson's disease, and some form of Parkinson's disease. The image in the left is a sagittal T2 of a patient of progressive supranuclear palsy or Steele-Richardson syndrome. This patient presented with downward gaze palsy, dementia, and bumping into objects and people. The image in the right side is showing the normal ratio of the midbrain and pons. But image in the left is showing the marked atrophy of the cerebral peduncles and the tegmentum. The pons appear as normal. The contour of the midbrain resembles a hummingbird or a penguin. This particular sign is called hummingbird sign or penguin sign. The midbrain atrophy of the Steele-Richardson syndrome explains the cause of gaze palsy, as the third and fourth cranial nerve is involved. These two nerves are supplying the extraocular muscles responsible for ocular movement, except the lateral oblique muscle. This T2 image in the left side is showing the normal colliculi at the quadrigeminal plate. In carry 2 malformation, there's fusion of the two mesencephalic colliculi into a single one, resembling the beak of a chicken. This is called beak sign. This sign is better shown in enlarged T1 sagittal image. The beak points posteriorly and at times may invaginate the cerebellum. You can also see the ptosis of the fourth ventricle, tonsillar herniation, partial agenesis of the corpus callosum in T1 weighted images. Joubert syndrome is a hindbrain malformation. The patient shows delayed milestone with ataxia, sleep apnea, and hypotonia. There is also distinctive facial features like broad forehead, arched eyebrow, ptosis, widely spaced eye, low setting of the ears, and triangle-shaped mouth. In the first image, we can see a normal fourth ventricle. There is indentation on the posterior wall of the fourth ventricle from the vermis. In the second image and the third image, in case of Joubert syndrome, there is a median cleft of the vermis. This clefting, along with thickened cerebellar peduncles, give the fourth ventricle the configuration of a bat wing in T2 and is known as bat wing fourth ventricle. This is a case of meningioma with intense contrast enhancement. On MRI, the thickened enhanced dura may resemble tail of a mouse extending from the mass. So it is known as tail sign. Dural tail was initially thought to be resulting from direct invasion of the dura. However, as subsequent studies proved it's a reactive process. The dural tail represents extraaxial lesion. Meningiomas are associated with dural tail in at least 60% of the cases. The dural tail sign, however, can occasionally be seen in acoustic neuroma and metastatic tumors. Rhombencephalosynapsis is a midline brain malformation. It is characterized by agenesis of the vermis. There is fusion of the cerebellar hemisphere. MRI shows transverse cerebellar folia and continuity of the cerebellar white matter from right to left. There is often aqueductal stenosis leading to triventricular dilatation. The coronal MRI resembles Donald Duck, and it is known as Donald Duck sign.
Animal crackers in my soup, monkeys and rabbits loose loose. Gosh, oogie, but I have fun swallowing animals one by one. In every bowl of soup I see lions and tigers watching me. I make them jump right through those animal crackers in my soup.
So by now we are quite familiar with a few animal-inspired radiological signs in the brain. Those signs are attention-grabbing, amusing, entertaining, and easy to remember. Oftentimes they facilitate the diagnosis. They also help us to narrow down the differential diagnostic spectrum. And with this, I'd like to conclude my expose and thank you very much for your kind attention. Thank you very much.
Thank you, sir, for your brilliant talk. We enjoyed all 3 talks and the huge learning for us from all the talks. So Professor Chumping, Professor Sujit Prabhu, and Professor Tejas. We are almost 2 hours in this session.
Shafiq, excuse me, Shafiq, Dr. Timo Krings is still on the line. Okay, if you have any question, you can ask him. And he has kindly decided to give another talk of the rest of his lecture, possibly next month. So he's still there. But if you have small questions, you can ask him. Thank you.
Anybody from the audience having any questions to all the speakers, please? Anybody from the audience having any questions?
Sir, I'm a third year resident. So can I ask you questions, sir, regarding a case?
Yeah, please.
Sir, Professor Timo Krings, sir, thank you for your excellent lecture. Sir, recently we had two patients referred from the pediatric medicine. Both of them were below 5 years, and they presented to us with MRI that shows hemispheric infarct. But after 2 months, the baby regained few improvement from the paralysis. We thought that it could be a case of a convulsion followed by ischemia. So what should be the management protocol in those cases at the first setting?
So in the acute setting, it is important to indeed differentiate whether this is a TOTS paralysis following a seizure or true ischemia. And for this, obviously, we would need dedicated neuroimaging. If this is related to true arterial ischemia, different management needs to be performed. But if it's a TOTS paralysis, then obviously the imaging would be negative, especially the DWI sequences. So in other words, if prospectively a child comes to you with complete hemiplegia and you don't have any clinical history, I think you need very good imaging to differentiate what the exact cause of the hemiparesis is.
Okay, thank you, sir. Thank you.
Sir, I have a question. So it is, I'm not sure it is stroke or is anything else. We often encounter pediatric trauma patients having hypodensity or stroke in the parenchyma. How can we correlate this? A few of our pediatric trauma patients having hypodensity in the CT scan follow-up. Do you have the answer to this?
That a treatment. That's it. Yes, treatment here. So.
Hello. Brigadier Jahirulam, sir, you have any questions or comments? Brigadier Jahirulam, sir.
Oh, thank you, Dr. Shafiq, for inviting me. Today we have I volume three sessions. I mean, 3 presentations. Professor Timo Krings, he is our old friend. We are habituated to listen his voice and his works. I should say works, and that has increased our experience in immensely. So our Zeta Chaudhary sir, he's always with us since long, and his everything is so amazing, and his image quality, the subject choice, he is for all, not only for the radiologist or neuroradiologist, he is for neurosurgeon, neurologist, and whatnot, internal medicine too. And we have seen a newer dimension in treatment of the brain tumor. It is being shown to us by Dr. Prabhu. So it's amazing. So definitely, our tonight's session is amazing and we have learned a lot. Thank you. Thank you to all.
Thank you. With this, our Professor Kanakanta Borosa is not available today because he is in flight today. And Musharraf Hussain sir, our President of Bangladesh Society of Neurosurgeons, he was in the meeting, but he has to leave because of this unfortunate appointment. So with this, can we conclude today's session? I'd like to thank all three speakers for their brilliant talk. Professor Sujit Tozu for his innovative work. We'd like to learn more and more on his work, and we'll study on the papers that he showed. And special thanks to Professor Timo Pring because he has already given his consent for one more talk in the next part. So thank you all the speakers. Thank you very much.
Thank you very much. Thanks. Thanks, Timo. Thanks, Rafiq.
Okay.
Thank
Bye-bye.
you, sir. Thank you
Thanks.
everyone for joining with us. Hope we'll have more seminars in future. Thank you all.
Thanks, Dr. Anis, for attending, Professor Anis. Thank you. Thank you very much. Bye-bye.